Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good morning, Dr. Asma, Dr. Dia, Dr. Sri Suparwitri. Okay. Assalamualaikum warahmatullahi wabarakatuh. Let we start the event for today. Good morning, everyone. We cordially welcome to our pre-conference and guest lecture of 4th International Dental Conference of Sumatera Utara 2024. Dear our honor, our Dean, Dr. Gigi Oktiara, she cannot join to our Zoom, but she give the regards for us. And dear our speaker, Dr. Asma Azari, BDS Adel, McLean Dent London. I'm sorry, Dr. Asma, I cannot really pronounce very well. Thank you for joining us and give the lecture to our resident. And we also invite to another postgraduate from other university. This is Dr. Sri Suparwiti and Dr. Dia. They came from Universitas Gajah Mada. Thank you for joining us, doctors. And we cordially honor for our participant. We have the participant from Medan also and also from another city. And first of all, let us say praise to Allah Subhanahu wa Ta'ala with His will that we could gather together in this event. And first of all, I have to read for Dr. Asma curriculum vitae before we continue the lectures. Dr. Asma Azhari, she is the specialist orthodontist and clinical lecturer at the dental faculty in University Kebangsaan Malaysia. She also served as private visiting specialist at Dental Avenue Klinik Pergigian dan Pakar Ortodontik, Putra Hedge, and Twin Tower Medical Center, KLCC. Dr. Asma did her Bachelor of Dental Surgery in University of Adelaide, Australia. She worked in Ministry of Health for a few years before she underwent specialist training in Royal London Hospital, Queen Mary University of London. Later on, she is awarded the Dental Clinical Education Experience Fellowship by the Royal College of Surgeons of Edinburgh in Orthodontic and Hypodontia Attachment. In 2023, she was nominated and won prestigious Roberto Justus Rising Star Award by the World Federation of Orthodontic for her groundbreaking research. She served as an examiner for the conjoint membership of Orthodontic of Royal College of Surgeons of Edinburgh and Doctor of Clinical Dentistry in Orthodontic in UKM. Within UKM, she is involved in various research, collaborations with national and international grants within the government, international universities, and industry, amazing published research papers in leading journals. Her expertise garners invitation as a review for high-impact journals and a speaker at national and international conferences. Dr. Asma Azari remains a recipient of numerous prestigious research grants of testaments on to her ongoing commitment to advancing orthodontic practice. In this morning, Dr. Asma will give the lecture about the preparation for MORT, Master Orthodontic RCS Edinburgh examination for orthodontics residents. I think this is our best topic, and I hope our resident will soon maybe get that together with this examination, hopefully, Dr. Asma. But maybe it's a bit like this is our stats. Hopefully, we can learn much from the UKM and other university from Kuala Lumpur, and you can share your thoughts to us, and we can learn so much about it. And soon we can perhaps join, maybe 1 or 2 years after. Thank you, Dr. Asma, for your willingly to do the lecture to us and give the lecture. Uh, I hope without further ado, let's start with the first lecture about this topic. And please welcome Dr. Asma to give the lecture for us.
Okay, Assalamualaikum and good morning. Thank you very much, Dr. Elira, for the very kind introduction. And thank you for everyone and for the invitation from FKG USU for having me here again. If some of you have, I'm not sure if some of you have seen me before. I have given a talk last year. I did come in person for the international conference, and I had a really lovely time. I hope to go there again someday. It's really nice. So this time I'm giving an online talk, and I'm thank you for being here so nice and early. Hope you all have had your breakfast, your coffee. Okay, so I'm just going to try and share my screen. Can you see my screen?
Yes, Doctor?
Okay. Okay, so Dr. Ilira have asked me to give a talk on preparation for the MORTH RCS Edinburgh for orthodontic residents. So is it compulsory for them to take the MORTH Edinburgh, Dr. Ilira?
Not yet, Dr. Asma. We have the examination, like the national examination only. We haven't do the internationally, not
But
yet.
is it compulsory for them to take the MORTH for them to become specialists? You
From
don't make it
Indonesia,
compulsory.
we
Okay.
we
For
take
us,
that.
for UKM postgrads, I think it is almost like compulsory. So all of our postgrads all took the MORTH, and usually it's Edinburgh because we had a conjoint examination last time with the Edinburgh, like Dr. Fraser, Prof. Fraser McDonald always come for exam. So it is compulsory for UKM residents to take the exam. But I think it would be very good if you could take the exam as well, since it is a specialty exam. And we all choose, most of us are Edinburgh grads, so that's why we are more leaning towards Edinburgh. For my batchmates, I think I was the only one who took Edinburgh. The rest took London, but I chose Edinburgh because we had a Morth trial, and I did better for the Viva instead of the OSCE, so that's why I took the Edinburgh exam. So I hope this is a nice intro and just some tips for you to prepare for the exam. Okay, so let's start with where do I work? So this is my workplace. Dr. Elira, Dr. Tia has been here. So this is University Kebangsaan Malaysia on the left. So you can see the main gate and the faculty is in there. It's in the heart of Kuala Lumpur. And that's my office right there on the right. So the surroundings is close to the biggest hospital, one of the biggest hospital in the world, the government, in the Malaysia, the government hospital, HKL, Hospital Kuala Lumpur. And also it is near IJN, Institute Jantung Negara. My brother coincidentally works there. He's a cardiologist, so we sometimes have lunch together. It's nice to work close to your brother. And then it's also close to the Twin Towers. And, I've taken Dr. Elira, Dr. Tia, we've all, had some lunch at the Twin Towers. So it's nice to have everything close by to the university. It's nice. Okay, so MORTH exam. So first I'm going to talk about the exam itself. So the exam overview, it runs over for 3 days. This is when I was there. I'm not sure the current one, I think is still 3 days. And you would have to quarantine in between stations. And there are summary notes that you could bring in. But sometimes they don't allow it. So I think to be safe, just prepare it with you. But in between, you can always have your summary notes to read. And it's important to stay calm and have your mindset, ready and confident, and just stay calm. Don't panic, because if you panic, you might get a mind blank during the exam, and we don't want that. Okay, so this is the result that they will give to you when you finish. This is the most nerve-wracking time, just waiting for the results. And when the results are out, just trying to find your candidate number and looking if you passed or not. So Alhamdulillah, I did pass. So they will show you the pass mark is the one in the middle, and then your mark is on the left. So, and then, you'll get this letter and, you'll celebrate after passing. Okay, so for your own cases, I think for my time, I think you have to hand in 5 cases, but I think now it's cut down to 3. I'm not sure. I think so. So you hand in your cases the previous morning and you have to check everything and all the models the night before. You need to make sure that the right models are with the right patient. I had someone that I know took the wrong model. So, it was the wrong model of the patient and that person failed. So make sure it's the right models. Don't bring the wrong models to the exam. And when you're there for your scene cases, so we call it, own cases, we call it scene cases. When you look at when you're with the examiner, the model's already in front of you and your booklet is already in front of you. So usually some people did bring their own notes and it is allowed when during my time, but we didn't. I mean, I think it's quite distracting. I mean, everything is already in front of you. So it's good for you to memorize your cases and know a bit about your cases so that you will look confident and you don't need to, when they're talking, going through your notes and talking to the examiner, that doesn't look good. So I think just be confident, know your case as well, and you have to memorize the summary statement for each patient. So for example, if you have case 1, 2, 3, 4, 5. So for case 1, you say, okay, this patient GB is a 14-year-old female presenting with a class 2 division 1 on a blah, blah, blah. So you know all the summary statements. So it's nice to start with that when because they're going to ask you, okay, so tell me about the case. So you must memorize the summary statement for each patient. Okay, so what will they ask for your own cases? So usually these are the common questions that they might ask. So how do you assess the skeletal pattern? How to assess anchorage demands for this patient? So for us, last time I gave a talk on space analysis. So that's usually how we measure the anchorage demands. So you look at the overjet, the degree of crowding, if there's any arch constriction, and if there's a curve of speed. So we look at all of that. And I think I've given a paper on that as well, if you want to look at that in greater detail. So also they would ask you to explain the KEF changes, explain your superimposition. Why did you do some things? Like if you did a CBCT, why did you do a CBCT? Or why did you not do a CBCT maybe? And yeah, so they might ask for, soft tissue assessment for the KEF. And I think it's important to lead the question. So it's when they ask a question, if it's a big open-ended question, it's nice to be organized. So for example, if they ask, how do you assess skeletal pattern? So you can say, okay, to assess a skeletal pattern, there are 3 methods. There's a visual assessment, there's a Kettle's method, and there's a zero meridian method. I hope you all heard of these methods before. I guess, as a postgrad, I'm sure you've been exposed to all these methods. So, when the examiner will go, wow, okay, this person is very organized and know the answers. So, for example, how do you correct the center line? Okay, there are 3 common ways to correct the center line, which is blah, blah, blah. In this case, I use the cross-elastic method, for example. So just be confident and also be organized when they ask questions and you want to answer them. So that would be my tip. And yeah, they would ask, for example, if you have a twin block, why a twin block, why extract, why that prescription? Dr. Ilira, may I ask, in USU, do you guys use one prescription for all or do you have different prescription? I think commonly MBT is the most common now, but do you still have different prescriptions?
Yes. Yes. Also, we have every prescription within.
Oh, very good.
Yes, the HYS, MBT, Roth, Andrews, everything.
So do you sometimes use different prescription for different
Yes.
patients? Yes, very good. That's how I was trained at Queen Mary. Now in UKM, we all just use MBT. So everyone just use MBT. So yeah, if you have different prescriptions, then you have to be prepared to answer that. I mean, I hope this is not only useful for MWorth, but also for your exams later on. They might ask the same question. So why did you use this prescription? So memorizing the torque, the torque values, the tip values is also important. I think we all had to memorize that anyway. And memorize smartly. You don't just memorize with the numbers, but you have a bit of understanding as well, so that it's easier to remember. Not sure if that's easy to understand, but I guess you get what I mean. Like if you understand, okay, so if there's more torque here or less torque there, then it all makes sense. So And for example, if you have a deep overbite case, they might ask you about the edge centroid. How was it achieved in this case? So if you have a deep bite, if you remember, there's a paper that talked about the edge centroid relationship. And when you achieve it, how do you achieve it? You look at the CAF. So say, okay, so in my, post-treatment CAF, this edge centroid relationship was achieved, for example. Mechanics, so like I said, if they ask about how do you correct the center line, you need to know other mechanics as well. What could you do differently? For us, we usually have to prepare alternative plans. So for each of your scene cases, you need to have an alternative plan. Even if it's just a different extraction plan, it's fine. But it's nice to have a treatment plan alternative so that if they ask, how could you do it differently? You said, okay, we could have treated this with blah, blah, blah. And of course, it has to be a workable plan, yeah, not something that's not workable. So you need to confirm with your consultants as well. Is this okay for me to do an alternate treatment plan for the exam? All right. Okay, so yeah, you need to learn your cases. You need to know the problem list, aims. Problem list is easy. The aims just complements the problem list, right? So you just need to know the problem list, the treatment plan, the CAF measurements and tracings. For us, we have the space analysis. So basically, the tracings ideally should reflect what we plan to do in the space analysis. So for example, if we plan to advance the incisors in a say, in a 2-div 1 case, the lower incisors will come forward a little bit. We plan to procline them a little bit. So have they advanced as per space analysis? Or in a class 3 case where we plan to bodily move the incisors, have they moved bodily or have they tipped instead of moved bodily? So I think for exam cases, you want to make sure that they follow what you plan to do. So I've made sure that, all the CAF tracings reflect what I wanted to do in my space analysis. And for us, we do have the space analysis in the write-up as well. And if it doesn't make sense, you have to be prepared to answer why. And you need to find questions from the write-up. So anticipate questions. So for me, I have all my patients' initials, and then I have all the potential questions that they might ask, and be prepared with the answers as well. Okay. And you can, I'm not sure, Dr. Ilira, for the residents, do they have a certain consultant to take care of their exam cases? Or is it more like whoever treats the case, they will get advice from the consultant that treats the case?
Actually, for each case, they have one consultant only.
Okay,
Unlike
but do they
the
have like
previous.
one consultant, like for example, one resident will be assigned to one consultant to look at all their exam cases, or it's more like whoever treats the case, they will consult the consultant for the exam?
Oh, sorry, Dr. Asma, do you mean for the preparation for examination?
Yeah.
Oh, sometimes they come with 2 or 3 consultants together and discuss for their case only. But actually, we only discuss our own case, Dr. Asma. That's the difference from Edinburgh examination. Actually, for last time we came to UKM trying to do the examination with Dr. Roshida. Uh, I think we have the new patient which we never seen before that we have to analyze directly in that time.
Yes, that's the unseen case, yeah.
Yes, I think that's different kind of the examination between the Edinburgh exam and our OSCE exam. Actually, if in Indonesia we have the OSCE exam, it's only came with one topic and we discuss only sorry, maybe like the cephalometric analysis, and it come only for cephalometric only. It's different to the Edinburgh exam that we all the result for one case from model analysis, the cephalometric analysis, and everything, and we have to do the examination and all the analysis until the treatment plan for the case. That's the differences, I think, Dr. Asma.
Okay. Yeah, so for UKM, for UKM's exam, we both have seen and unseen cases. So the unseen is the one where you have to look at the case and just diagnose on the spot. But for the exam, when you choose cases to bring to the exam, at Queen Mary, like we have one consultant assigned to each resident to look at all their exam cases and give opinions. But in UKM, we don't. So whoever consultant that treats the case, it will go through the case with the postgrad. So it's different consultants for different case. To me, it's fine, but sorry. It's important to get opinions from, if you want, you can get opinions from different consultants as well. Sorry, I have a cough going on.
Dr. Asma.
Because I'm breastfeeding, so I can't really take many cough medication. So yeah, it's been going on for a while already. So I might mute in between, sorry. So yeah, it's good to get opinions from different consultants. Maybe not too many, maybe just, after you've done one case, maybe if you want, you can get another opinion if there are some things that, you just want to get a different side of view from, because everyone looks at a case differently, and sometimes there's no right or wrong answer. So during my time, I went for my scene cases, sometimes I get another consultant's opinion, but not too many, because sometimes it'll get you confused. So not too many. Maybe one or two is fine. Okay. So for the exam, for during our time, we have to have 5 cases, and usually there's one big case. So either, functional with extractions and ectopic canine, or, extractions with anchorage reinforcement, maybe with TAD. So we have one big case, and then 2 moderate cases, which are extraction cases, with some sort of mechanics going on. And then we also have 2 simple cases, like a class 1 malocclusion, or you can have like just an upper extraction case. You can even have a non-extraction case if you do. So if you see on the photo on the right are my I gave 2 examples of my exam cases. So the first one on the top is a 2-div2. It's actually a non-extraction, but we use the headgear for distalizing. So, that was, even though it's non-extraction, it's suitable for exam because, it's very deep, severe 2-div2. The patient's profile was, quite moderate skeletal 2, and she achieved good soft tissue change after that. And in contrast with the lower photo is this patient of mine for my MORTH was oligodontia case. I think he had 8 missing teeth. He's missing 2s and 5s and 7s and 8s, which doesn't count. But yeah, he's missing all his 7s and 5s and upper laterals. So if you look at his finishing, it's different from the person on the top, because when you have a non-extraction case, if it's a bit simpler, then you're expected to have really good finishing. But in contrast, if you have a really complicated case like a hypodontia, multidisciplinary, they don't expect you to get perfect finishing, because in the real world, sometimes it's not possible. And there is some compromise as well that, you can accept, you have to accept. So in the hypodontia case, you can see how it's, the overbite is slightly reduced, and it's not like as perfect finishing as the top. So just remember, for more complicated cases, you can be a bit more forgiving in the finishing, and they understand that. Okay. So yeah, it's when I was training, we had like about 10 cases. First it was 20, and then we rounded up to 10, and then you go through with all the supervisors. So maybe 3 or 4 consultants, we have a look and give opinion on which cases do they think is best. I'm not sure how it goes there, but if you don't have that, you can always just get one consultant's opinion of, is this okay for an exam case, etc. Include all photos, because you need to choose which photo to put on there. So sometimes there is a bit of, sometimes you can like sort of not put photos that you don't want to show them. So for example, like TPA, NANS, some consultants in the Royal London, they hate NANS. They hate TPAs. They don't think it's a good anchorage at all, except for vertical anchorage. So cases that I have a TPA, they say, okay, just remove that photo with the TPA, just include those without the TPA. So, those sort of things. So you can sort of, have an artistic license to like tweak and choose the photos that you want. So include all photos when you're presenting with the consultant, so that you can choose the best ones to put in the write-up. And finishes is important as well. So make sure you have nice finishes. Closer to the exam, you might see your patients a bit more often, maybe 3 weeks or maybe every 2 weeks, like I did when I was about to finish. And it's such a relief once you debond your exam cases. It just feels so good once you've debonded and you can start focusing on your write-ups. Okay, so now we're moving on to the unseen case. This is where you get a case and you have to diagnose on the spot. You'll get 15 minutes for each case. You get four different pairs of examiners, but some can be the same. I had one same examiner, like two cases. I had the same examiner, and he was so nice. He's from Glasgow. I think his name was Dr. Professor Goss. He was so nice. I really had a good time doing my exam with him. So we had two cases in a row. So 15 minutes of prep. You need to spring onto your seat. Don't panic, but yeah, just be ready and be prepared to organize the records. And you sometimes, for us, we had an extra few minutes while you queue to enter the hall. So you can still have your notes with you and still revise some things. So yeah, remember to always bring your summary notes because it can still be useful. So I think it was quite a while before we wait to enter the hall. So sometimes you can still go through, your mechanic notes and, for example, ways to correct a center line, ways for anchorage reinforcement, the evidence for anchorage. So you can all read all that quickly before you enter the hall. Okay, so read the patient's details carefully. So you want to know the patient's age, the patient's main concern, etc., so that you don't get them wrong when you're presenting and it doesn't affect, how you treat the patient. So what I do is I look for them at the models for 30 seconds. I get an overview, get a summary, and then you do the diagnosis, assessment, and problem list for 8 minutes, and the aim, objectives, and treatment planning for 7 minutes because you have 15 minutes. So that's how I plan, and that's how we usually are trained to plan our cases when we do the unseen cases. So you have about half and half. Sometimes some people bring a timer. So if you're stressed out and you don't want to look at the timer, maybe it's best not to, but always remember to keep your time management properly. So halfway, you actually need to go through at least, finish the assessment and start with a problem list halfway. This is, I mean, you guys can screenshot this if you want, but this is how we do the unseen cases. So when we have a sheet of paper in front of us, when we do the unseen, we'll divide them into these boxes. So the first part would be the summary, and then extraoral, intraoral, upper arch, lower arch, space requirements, and then the type of occlusion, OPG, what are the things that we see, KEF, the measurements, and then the problem list, treatment aims, and then treatment plan. So this is how we usually organize our information before we present to the examiner. I can pass this to Dr. Ilira as well after this if you want. I can pass the PDF so that you can pass it to them. I think for me, extra oral, you don't have to put extra oral skeletal, extra oral soft tissues. So for me, I just do extra oral and then intraoral, upper arch, lower arch. So just as whatever is quick that you can do. Basically, when you do extra oral, there's going to be soft tissues, there's going to be skeletal. So just make sure that you don't miss anything out. Okay. Okay, so practice is very important. You can start practice initially with no time pressure, and then closer to the exam you can start doing the 15-minute timer. Try to get as many different people to examine. You can get consultants if they're free. So FTTAs, I think in Indonesia you don't have FTTAs, right? In London we have FTTAs. They are specialists who are training to be consultants, and also your own colleagues. You can practice with your own colleagues as well, though they're probably not the best, but you can work with what you have. So for us, we actually approach consultants, and for UKM, we actually have a sessions of practice with them, but we have that with our consultants as well, but we approach them to get extra sessions. So maybe just 1 month we get one consultant to do a practice on all of us. So we find a case for them. So we find a case from one of the residents who are not in our year. So it's a case that no one has looked at before, and we give it to the consultant, and then he will do the unseen case with everyone, and we get the timer, the 15-minute timer and everything. And we also get the FTTAs as well. So our batch was very good that we had we sort of had a timetable for different people every week. I think every week closer to the exam we had practice every week with different people. So it's really good that it practice and makes you less nervous for the exam as well. For own cases, you can have you have formal unseen practice with your own cases, with your colleagues' cases. And while we're waiting for in clinic, even in clinic when you're doing seeing patients, when you go to your colleagues cubicle, you can actually look at the model and try to practice what would be your plan and see if it matches what's the actual plan was and try to justify, So I always tell my students not to put, I don't know if you guys do this as well. Some of them like to put X with a pencil for extraction, which tooth they had extract. Do you guys do that as well? Yeah. So I told them not to, because otherwise, when you look at the models, you're going to know what the plan is. So for example, if you go to someone else's cubicle and you want to guess the plan, you can't, because there's already the X on the model. So what you can do is you can just put X on all the teeth so that they don't know which tooth it is, so that you can practice. So it really helps. So when they go to someone else's cubicle, if I'm supervising, I would say, okay, I give it to them. Okay, guess what's the plan? So it actually helps you to be on your toes and thinking and start thinking. And it's actually an unseen case practice by itself, like an informal practice. So yeah, you need to have a summary statement for the unseen cases. So when you see the examiner, you need to say, okay, the summary statement, like I showed you, is the first, if you look at the first box is the summary statement. So when you see the examiner, you will start with a summary statement. This patient presents with a class 2 division 1 on a skeletal 2 pattern. She presents with crowding, severe crowding upper and lower arch, blah, blah, blah. The malocclusion is complicated by caries on blah, 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 and a non-vital, blah, blah, blah. So start with a summary, good, solid summary statement. And then, yeah, go through practice going through the CAF as well, and also treatment planning. It's really important, and always try to have an alternate plan. And when you do the treatment planning, you have to prepare for some mechanics as well. Are you bonding the sevens? Are you going to use lace backs? Are you going to do push pull mechanics? Are you going to use mechanics for overbite reduction? Are you going to use elastics? So try to have a bit of the mechanics as well. So you have to remember, if it's a simple case, then they might have time to go through the mechanics. So you might be prepared to discuss some mechanics. If it's a really complicated case where you have to, it's just so some cases were horrible. Like it was, high angle 2 div 1 with, missing tooth and severe crowding in the lower, but the mandible is so set back, so if it's a really complicated case, you might not have time to go through the treatment plan, because it's just so complicated that you spend a lot of time discussing the earlier bits. So for a complicated case, you might not have time to go through the mechanics. So just keep in mind that the more simple the case is, the more time you have to discuss. So you might go through mechanics and everything. So just keep in mind about that. Okay, so you need to have a good summary statement. More than one treatment plan is good to have. And you just have the mindset that whatever that you write, it might not go according to plan. So whatever that you suggest to the examiner, they might say, okay, no, I don't agree with that. Why don't you do this instead? So you have to be prepared to just reverse and just replan a new one according to what the examiner suggests. So be prepared for that. Some people just like panic, like, oh my God, like I'm not prepared for this plan. Oh, I cannot think anymore. So just be prepared for that mentally, so that you're calm and okay, yeah, I can just do this different plan, mechanics wise. So just be calm. And one thing that I've been told that's not good, it doesn't look good when you change your plan in the middle. So try to be confident, unless they glaringly said to you it's wrong, then you can change your plan. But if you've stuck to something, try not to change in the middle, because it doesn't look good, as someone that's just suddenly changed the plans. Just doesn't look good. And stick to what you know. So for example, if you're going to say TADs, you have to be prepared for them to ask, okay, so what are the benefits of TADs? Where are you going to put the TAD? What measurement, what length of TAD are you going to use? So if you want to say something, make sure you know what you're going to talk about it afterwards. Okay. So if you want to talk about, if you have a case with root resorption, for example, be prepared to know the mechanics of root resorption, the types of root resorption, the classifications, Lavender and Malgram. You need to know the papers with that. So just remember, if you want to say something, you have to anticipate the questions afterwards and be prepared as well. Okay. It's good to have a good shorthand system, so that you save time when writing, because if you write too lengthy, then you might lose time. So again, like I've mentioned before, you can have a digital timer because you can't bring your phone, or you can have your watch. But if it stresses you out to see the timer right in front of you, then don't. I think I did bring a timer for myself. Yeah, so if you look at this one, the occlusion, sorry. So we always have like a line, for the center line, the canine relationship, the molar relationship. If you look at the occlusion part, the numbers there. So center line, canine and molar relationship. So you just do a line as, so we do like a horizontal line with vertical lines. So the middle one is the midline, and then the one next to it is the canine, and then the last is the molar. So you don't have to write canine relationship, molar relationship. So you just do this and it saves you a lot of time already. So that's how, we are trained to do, the records. Um, okay, so that was about the exam. Does anyone have any questions at this point? I'm happy to answer before we go into how I prepped for the exam.
Okay, for everyone here or maybe in Zoom meeting, is there any question for the previous topic? Uh, Maybe I will ask for myself, Dr. Asma. Can I ask about the seen case and the unseen case? It means that they have to have the examination for two kind of exam, for their own case and the unseen case. Is it, Dr. Asma?
Yeah, so there are two, yeah. And there's the viva as well and the communication. So I think the scene cases, they've cut it down to only 3 cases that you need to bring, but I'm not sure. I think there was talk about eliminating the scene cases altogether, but for my postgrads who went to Chennai just recently, they still have the scene cases. Yeah.
Oh, okay. So, should we, as a lecturers, for the examination, we have to prepare the case for the unseen case. Is that, Dr. Asma?
Yeah, so yeah, we do have like what you did when you came to UKM. So it's just a new case that they haven't seen before. So they have 15 minutes to look at the case and diagnose and have all the, problem list and the treatment plan as well. We have that for actually for their final exam, we have that as well for the students. I think 2 cases that they need to do. And usually it's very, very, we give them very, very difficult cases.
Yes, actually, indeed, very difficult, Dr. Asma.
Yeah.
A bit like surprised, what is this case like this?
Yeah,
But
yeah.
maybe, yeah, this is the last grade that joined to UKM last year.
Did they, because I wasn't, I was on maternity leave,
Yes, you're in
right?
the
So
community. Yes,
did
we
some,
maybe three of us, three of you. Yeah, Fanny. How many of you came to the trial for the examination? 3 orang ya, yang ikut ujian kemarin. 3, 3 students, Dr. Asma. They try to
ah,
join for the like the practicing the examination, because this is the new for us that they became like very surprised this case, and we have to see the case only 15 minutes.
yes,
Have
only
to
15.
see the first like the glares of the, we have to glass every every the model analysis, the
Yes,
metrics and everything. Then they have to they have to make the from the diagnosis until the treatment plan. Yes,
yes.
I think
Yeah,
for
so
us
that's what
they
we
had.
the one that I suggest, to do the everything 30 seconds for overview first, and then to diagnose assessment for 8 minutes, and then the aims, objectives, and treatment planning for 7 minutes, so that you can try to like make sure that you're on track. That you don't, sometimes you spend too much on examining until you pass the 7 minutes, you're still looking at the model, then you know that you need more practice. It's not enough time. So you have to be quick because it's 15.
Yes, because it was the first time for them. I think the 15 minutes doesn't
Yeah,
enough.
because they're never trained, so it's fine. So that's why this thing needs a lot of training. Yeah.
Yeah, I
Mm.
heard that in UKM also always in the Friday they have to practice the examination every Friday. Is it, Dr. Asma?
No, not really. Every
Not really.
Friday we have journal club and we have seen cases present. It's more like they're presenting someone's case and discuss what went wrong, etc. So we don't do unseen cases, I think, until closer to their exam. Then we have.
Oh, I see.
So we usually have it with each of the consultant will practice. We'll have one round with them. Yeah.
Okay. Thank you, Dr. Asma. Is there
You're
any other
welcome.
question from audience in the Zoom meeting? Uh, we,
May I know how many of them are planning to take the MORTH Edinburgh, the one here?
I think they haven't decided for join the exam, but
Yeah.
we just perhaps maybe we can do this exam for the my resident also say no just now. No. Never. They only seen for their own case, Dr. Asma, actually. For the examination, they haven't give for unseen case.
Oh, they don't, so you don't have unseen for your examination.
Not yet. Perhaps later.
Yeah, perhaps it's good to do it.
Yes, I hope. One
Yeah, be
can
like,
say,
no, but it's actually good practice. I mean, that what to me that is what is the challenging part because that's why for Edinburgh they're gonna eliminate the scene cases because they say it's just it's just a show because you choose all your best cases, everything went nicely. So it's the unseen is where you're like, oh, like you have to prepare the plan, everything. And you know how I said there's the FTTA, the specialist training to be consultants. For the unseen case, I think they only have 3 minutes.
only 3 minutes.
Yeah, so they're given like a case and they have 3 minutes to like just diagnose and do
Oh,
the plan, something like that. I was like, oh my goodness, even 15 is like tight. They have 3 minutes to do it. So yeah.
so hear that, guys? 3 minutes, 15 minutes. One case for our examination, our compre. Perhaps maybe for the next examination, we have the comprehensive examination, but that came only from the scene cases only, Dr.
I
Asma.
see. Yeah, I think
Perhaps
for
like
Malaysia,
yours.
it's all, I think UKM, UITM, UIA, we all have unseen cases for our final exam for the residents. Mm.
Perhaps we can consider about that again. Later, Dr. Asma. Perhaps I think we need your suggestion. And this is the first time that you give the lecture, so we have the open mind to do perhaps for the later examination, Dr. Asma. Thank
Yeah,
you.
sure. Okay, so now I'm going to go through the MWorth preparation. So this is how so the first part was the exam itself. So now it's the preparation, how I prepared for the exam. So my own resources, I think everyone used the same. So books, papers, keeping up with the evidence, courses, and these are all courses that's offered by Queen Mary at that time. Unseen case practice, like I've told you before, we approach consultants, FTTAs, and our own colleagues as well. But with our own colleagues, it's funny because we're at the same level. So trying to be like a consultant and go, oh, why didn't you do this way? Or like it's a bit like, a bit like short sendiri, like orang cakap. Because you're just with your colleagues, but it's fun anyway. It's nice to do it. Um, New patient clinic. So I'm not sure. This one we don't have in UKM. Well, we're starting to do it, I think, next year because I'm the coordinator. So I'm starting to start something like this. So they basically the postgrads are involved with a screening clinic as well, which are new patients that come in to screen whether they're suitable for ortho treatment. So these are new patients. So what we do is when they see the patients, we test them on the treatment plan as well. So that's what we do in London. So for these patients, even though you're not treating them, you're not the one seeing them later, but you ask them, okay, so what is your plan? What are you gonna do after they've traced the calf and everything? So it's good practice. So that's when they ask you the papers, who said this, who said that. This was during new patient clinic. So that's where I learned. And I have a small notebook during new patient that I bring, for all the things that I discussed. And nice to have a study group as well. So in this photo, I have some of my friends there. There's some nurses as well, but my friends, we study together. So it's nice to have a study group so that you can always test your friend, because sometimes what you read is different from what your friend reads, and what you focus on is different with what your friend focuses on. So it's always good to study. You don't have to study everything together, but have someone to be around, or a few people to be around you, so that when you don't understand something, or when you're trying to test something, it's good simulation. If you just study alone, it's like very restricted, and you're just doing it by yourself, and it's more fun anyway. And exam tips, you get this from your seniors, so they would give exam tips. So my seniors at Queen Mary, they were very helpful. So make sure you ask your seniors for help. Past papers. So I am going to provide some past papers to Dr. Elera, so that she can pass it over to you guys, of the Edinburgh exam if some of you plan to take the exam. So I think she may pass it um, to the representative or something, and he can dissipate it to those attending this lecture. Okay. Um, and it's good to have your own notes and summary papers as well, so that I have my own notes. And yeah, so these are the books that I would recommend for the Edinburgh exam, and I think it's good for any exam really. So the Handbook of Orthodontics, I think they have the third edition now. You must finish the book, and you must know the book by heart. I think it's so easy. For the second edition, they've started having papers quoted next to what's been said, and they also have I think at the end they have the type of paper and what's been described in the study. So it's so easy. I think, if you just read that book, and know it by heart, I think it's fine, just for the exam itself. And there's a clinical cases in orthodontics by Fleming and Colburn, I think. So that one I think is a very good book to have, and you need to read through that book as well, because they talk about mechanics, they talk about treatment planning. And what I did was, when I went through the book, when I looked at the cases, I don't look at the answer just yet. I try to do my own treatment plan and then see what they decided to do. And if it's different, then why? And then I learned something. So I think that's a really good book to read. For some difficult topics or certain topics that's difficult to understand, I think the profit book is good to read. It's that huge, that profit book. I'm not sure what you guys are recommended to read, but I didn't read that whole book because it's too much for me. So I only read it when there are certain topics that I don't understand. I would go through that book because it explains everything in a more detailed way. The MBT book is good as well, because I think you all have these books online, I think. But I don't like online. I like to read it in real life, because I think online just strains my eyes a lot. So the MBT book is good on mechanics. Bristol notes, I'm sure you guys have that as well. I'm not sure, but my postgrads have them. You can cross-check with the handbook, because the Bristol notes is all about papers on topics, where the handbook has a bit more explanation. Handbook of Orthodontics have explanation explanation with the papers as well. BOS guidelines are important as well. Isaacson's X-ray guidelines are important as well, because it talks about X-rays and what is justified to take, what is not justified to take. When I had the exam, I had one of the students said, they were asked, why did you take this X-ray? And he said, yeah, because of this. And would you take it if it was your daughter? And he answered, I don't have a daughter. Actually, you shouldn't answer that. So basically what the examiner meant was, would you take it if it's your own family member? And he just answered, no, I don't have a daughter. And he doesn't answer that question. So yeah, he didn't do well in that part. So yeah, X-ray guidelines are important, because it's always about minimizing radiation and try to, with the UK, they want to minimize radiation, I think everywhere as well. So only take it when you really need it. There are guidelines on CBCT as well. So you don't take CBCT for all canine cases. When it affects your decision on treatment planning, then you take it. If you know from the X-ray, from the periapical and OPG, for example, that there's severe root resorption and you're going to take out the lateral, even if you take the CBCT, then you don't need to take the CBCT. So the Isaacson's guidelines talk about that. So I think it's important to read as well. McDonald and Ireland book, I think it's important for Edinburgh exam, because there's a materials book. It's very simple book. It's a very small book, but they talk about materials, and it's a common exam question in the past paper. So we all read that book if we're taking the Edinburgh. If you're taking the London, I think that book is not as important. I mean, you can read about materials elsewhere, but somehow these two books, what they state in there is actually what usually that's been asked. So I would read those two books as well. And the VLE notes, this one, they're very detailed. They're old modules. There are newer ones, but yeah, I did read them for some topics. If you don't have it, I mean, it's not compulsory to read anyway, but I think the handbook, the rest are good enough already. So papers, do we need to memorize them? This is a common question by our postgrads because sometimes we do ask about evidence, like where did you get this from? Why would you do this? So for Edinburgh exam, sometimes they do ask about papers. So you basically need to know key papers to pass, but to get better marks, it's nice to offer, some evidence to what you're saying so that it just strengthens your what you're doing. um, when I had my MClinDen exam, we were asked a lot about papers, but for MORTH itself, actually they don't ask you so much on papers, but like I said, it's nice to offer the evidence. Yeah, the Handbook of Orthodontics, they've done most of it for you. They already have, what paper says what, and it's a nice summary. So I think the latest edition is probably better. And you just I think even if you read that and without the Bristol notes, I think it should be okay because they've already have all the important papers in there, and if you know them, it's fine. um yeah, so I always incorporate the papers and the year, the author and the year in my own notes, and I have the citation in red, so it's easier for me to remember. And you need to have the summaries of important Cochrane reviews as well, and know the latest papers and also the classic papers. So for, keeping up with the evidence, there's always latest evidence. So journal club is a good way to know the latest papers that's been discussed. Usually, with the lecturers, if I get to choose a topic, I would like to choose a topic that's quite new and to update the evidence that's already there. I'm not sure if you all follow Kevin O'Brien's blog, but that's also a good source to look at papers that's been discussed, and he critiques the journals as well. So it's a good practice for um, reviewing journals as well, seeing if they're the right standard. But lately, I think his blog is a bit boring now. I don't know. Maybe um, he's also run out of ideas which paper to use. And if you're more into it, you can search PubMed and you can look at AJODO and EJO new issues. But I don't do that. I mean, I'm not that excited to go through all the new journals, but you can if you want, and that's good if you have time. For me, I don't have time to do that. So for me, just journal club and just going through Kevin O'Brien's and is enough for me. The rest is all in Bristol notes and it's all in the reading list. My reading list is very outdated. So every university, Queen Mary, every year they will have a reading list. So they would give all the papers that you need to know. But mine was, I graduated in 2017, so that's 7 years ago. So, they're not the latest papers, but they do have classic papers in there that you need to know. Okay, so courses offered would be useful to have. I'm not sure about your university, but we had the MORTH revision course. And this is when I decided to do Edinburgh exam because at this time I did really well in the Viva, but not so well in the OSCE because I think OSCEs are quite stressful because there's a station, you need to go to the next station. So Viva I did really well, so I decided to do the Edinburgh, even though it's earlier than the London. I had to prepare my cases earlier, but I think it was worth it. We also have the straight wire course and the functional course. So maybe this doesn't apply to you guys, but um, hopefully, if you guys plan to take the exam, you have the support that you need. I think the consultants will help you as well if you want to go maybe and do some practices with you. So for the notes and summary templates, I usually condense my notes with the type of topics. And again, I would write the author and the year of certain papers in red. And it's something that I can bring anywhere so that I can, I can bring them in the train. I can read them anywhere, basically. And new patient notes, I have a book for that, a small just book, just scribbles, but it helps to just go through them. And because they will ask a lot during new patient, they'll say, okay, what are the things that would indicate cross-bite correction, or what are the things that causes this, causes that. So it's a lot of things that they ask a new patient where I have it in my notes. And you need to have lists for, clinical examination, unseen cases template, what to write. So you need to have methods to reduce overjet, methods to correct center line, methods to reduce overbite, things to avoid in high angle, low angle, things like that. It's nice to have for unseen cases so that you can prepare what to say if you decide to do this or that. And everything is by topic. And for me, I had a study timetable by topic because I'm easily distracted. So I need to have a day where I do, I need to have a timetable so that I can try and stick to it. And it depends. I think this is something that's subjective. So whatever that suits you. Yeah. So this was after I finished my Edinburgh. I don't have any of my Queen Mary friends here because they all took the London. So these are my some of them are new friends and some of them are Malaysian as well. So how was it for me? I think my brother accompanied me when I went to Edinburgh because my husband had to work at that time. So he helped me shine up my models as well. He helped me. My brother, who's now in IGN, so he was a doctor at that time, so he took leave to help me bring me to Edinburgh. And I think the first day we went, the day after was the exam, but the day before, I think we went shopping because it's just nice, it's nice not to stress out too much. For me, it was a very pleasant exam, to be honest. I think the examiners were all really nice in contrast to London, where my friends said the examiners were really horrible and they make you think that you failed the exam, but actually you didn't. So that was how London examiners were. But for Edinburgh, they were super nice, super friendly. And I felt really good after each exam day. I remember I was just really confident after the exam because everyone was really nice. They don't make you feel bad at all. Um, so yeah, it was a nice experience for me. So yeah, these are just the cases that I get asked on. This is the unseen cases that I get asked on. So it was an asthmatic case, discuss about, the how asthma affects, any of your orthodontic management. It was a mild 2 hypodontia, spacing of 10 mm. There were caries. There was caries as well in the lower left six. So it's something to think about when there's spacing. You don't really need the space requirement, but then you have a secondary caries. So what are you going to do? How are you going to defend your plan? Okay. So my treatment plan was Pontic upper laterals, and I plan to retreat the six. So even though you have a caries on the six, but you don't have any space requirement, there's already spacing. So it's not justified to extract the six. I think some of them do say to extract. I'm not sure if they pass or fail, but I passed. Yeah, so I think if there's no space requirement, don't suggest for extraction. Yeah, because unless there's a space requirement, then you can extract. Um, Especially in a hypodontia case. And it's really important to mention it's a multidisciplinary case at the start. So if you know that there's hypodontia or if there's an ectopic canine, so you mention at the start before your summary, you will say this is when you go to your plan, you will say this is a multidisciplinary case involving expose and bond of the canine. So they know that you are aware that it's not something that you do on your own. It's something that's multidisciplinary and you need other specialties to help you. So the second case was a class 3 high angle skeletal 1 severe crowding of 16 millimeters, upper right 5 impacted, lower severe crowding excluded. So yeah, I did RME, rapid maxillary expansion for this case, a 4-unit extraction and headgear. So they were like really horrible, some are really horrible, difficult cases. And this third case was a 2-1 high angle, missing 1 lower incisor. And I think yeah. So it was really confusing this one because the missing incisor and the central line has shifted as well. So I decided to extract the lower left 4, camouflage the 3 as an incisor. So the central line will change. So the central line is nicely on if you camouflage it. I remember that because otherwise it's impossible to get a good center line. So if you camouflage the 3 as an incisor, then the central line will be nice. So this was a very confusing and difficult case as well. So yeah, that's the kind of cases that you might get during my time anyway. So case 4 was a skeletal 2. I think this one is a bit more simpler. 2 div 2, full unit 2 molars, ectopic canines. So I did twin block and modified it to retract the canine on the twin block. And they asked me about, I remember they asked me about the parallax technique as well, if the canine was buccal or palatal. So yeah, those were my cases. So I think this one, I missed 1 mark on this. So I think for the overall exam, I was short 2 marks. So I think I got 86 out of 88, I think, or 86 out of 87. But I think this is because of this case. Because when they asked me to do the parallax, I think I was a bit slow and I wasn't sure which was it, buccal or palatal. I was a bit confused because it was like in between the two. So I think that's where I lose the mark here. Yeah, so That was the fourth case. So Viva, I got asked on deep overbite, how to reduce deep overbites. Oh, they asked me about papers on this one, all the papers you know about overbite. So we talked about Selwyn and Barnett. Who else? McIntyre, I think, talked about the etiology. I still remember some of the papers. So yeah, so they do ask about papers as well. And the second one, it was about standing. They give me a photo of the standing height chart and height velocity. So they ask the pubertal growth spurt for males and females. How do you measure the peak height velocity? And what are the advantages of treating patients during the growth phase? And then another one, they ask missing lateral with a cyst, what would you do? Advantages of CBCT, they ask about how to reduce radiation, because I think it's a big thing. Doing that's why most of the studies, when you go to the conferences, if they use a lot of CBCT, they're not going to be able to publish it in European journals because they're very conservative. They want to try and reduce radiation on patients. And I think the person who won the award for the best journal did a study on how to reduce radiation on patients. So they tested OPG, they tested one with slightly lower dose and they find that they're both diagnosable. So she won the award for that. So they're very keen on reducing radiation on patients. And yeah, so they ask about supernumerary as well. What are the incidents? What are the evidence talking about incidents in supernumerary? OPG transpositions, root resorption, and arch wires. They ask about the formula, DR4 over lower L3, and they ask different scenarios. If length was changed, what happens to the force, blah, blah, blah. Different types of arch wires, different generation of arch wires. And I was asked to draw the curve to get extra marks. So I think I already got marks at that point. So he said, okay, if you want extra marks, you draw me the curve of the superelasticity and thermoelasticity curve and explain the graph. So I think I got full marks from my Viva. So I did well in my Viva. Okay, so these are the scene cases. I was asked how to assess profile, instructions with headgear, safety features of headgear, why not functional, age in protraction face mask, stability of RME. So there's a latest systematic review by Legravere, and RCP versus ICP, alternate plan, blah blah blah. So these are all the questions that they can ask, in seeing the cases that you do. So this was what I was asked by the examiners, and they also asked if the retainers keep the roots parallel, for the patients. I said it may have an influence, but you have to consent that the patient's roots may not remain parallel. And they also asked me how many percentage of the terminal flush plane go into class 2 or class 3. Wow, that one I didn't know. So life after Amorth, yeah, this is the ortho. This is a very old photograph, actually. This is the ortho department. So this was with our postgrads at that time. They're now all specialists. And the one in the second line, the middle line, are all the specialists in UKM. So that's Dr. Aznan, Dr. Asma, she's left. She's now in USIM. Prof. Rohaya, Dr. Alize, myself, and Dr. Norsam. Now we have a new Dr. Imran. I think Dr. Elira met him that time in Malaysia, the tall guy. Yeah, so we have a new lecturer as well. Working life in UKM, we have to fill a logbook, your own cases. It's a different epidemiology in the home country, but I guess you guys are fine because you guys treat patients in Indonesia and will work in Indonesia. So when I treated patients in the in the UK, I don't have many BIMAX cases, and I don't treat adults in the UK because they're all NHS patients, so they're all under 18 except for orthognathic patients. So it's something different when I come back and I said, oh yeah, so it's more adult patients, so it's different. So in the beginning, you always have, it's nice to work in university, I feel, because you have colleagues and old friends to discuss with. And you have to accept the idea that we all don't have the same plan and we are all trained differently. So that's okay. And we always have a learning curve, even after MRth. Even now, I'm still learning new things. OGN and CLAF patients, I don't do that many in the UK because that is mostly done by FTTAs, those training to be consultants. In Malaysia, we don't have to train to be FTTA, we are already called consultants. But in the UK, you have to do extra training for that. And so, yeah, I don't see many of those. So when I'm in UKM, I learn a bit more about those cases. So it's a learning curve. And yeah, for 1 week in UKM for me, I have my own clinic, time to do research, but it's mostly the students that do the research. I guide them. And we have postgrad students, clinical supervision, and also undergrad clinical supervision. That's how it is a day in UKM. And also, of course, I have my private practice as well. They are not my own clinic, but I work as a visiting specialist in those places. Yeah. So, it's nice to have a bit of private practice as well. So that's where I practice Twin Towers Medical Clinic. It's on the fourth floor in KLCC and also in Dental Avenue. I think it's always nice to have a bit of private practice because, you can do a bit more aesthetic stuff like Invisalign, ceramics, and lingual. And there's so many new aligner brands now that we can try out. So that's nice to do as well. Um, so yeah, it's for you guys when you go out there, it's nice to find the best clinic before you start, because I'm so glad I choose these two clinics because I'm happy there. Some of my friends, because for ortho it's not like you choose one clinic you can jump to another clinic the next few months. No, because once you commit with a patient, you're going to have to complete their orthodontic treatment. So you have to choose a really good clinic because it'll be difficult to leave your patients that you've already started. So make sure you find a nice one that suits you before you start working. So yeah, further training, FTTA, we don't have that in Malaysia. I don't think I have that in Indonesia as well. Subspecialty, if you're interested. I'm not so interested in subspecialty because I'm not so interested in cleft or orthodontic. Unfortunately, I'm more interested in aesthetic stuff. But yeah, you can do that if you want. PhD, fellowships. So I did my fellowship in clinical and dental education. This is because one of my previous consultant told me to apply for it, and he said he can be the referee. So I applied for it because he told me, and I got the scholarship. So he was really nice, and it's nice to keep relationship with your consultants as well and your friends. So I have a friend from Cardiff he's now a consultant, so we do papers together, etc. So it's really nice. Yeah, clear liner courses, lingual courses. I think you can all do that after you graduate, or I'm not sure if you provide that training before you graduate. I'm not sure. For UKM, I think we're starting to collaborate with Invisalign so that they get the certification before they graduate, because the certification is very expensive otherwise. So we're planning to do it for free for our undergraduates, postgraduates, because I got it for free as well when I was in Queen Mary. So I don't have to pay extra, because I think it's about 12,000 or 10,000 ringgit to get certified for Invisalign. So good luck. So yeah, these are all my good friends when I was in Queen Mary, and I still keep in touch with some of them. The one next to me, the guy next to me, yeah, that's the guy that I'm still doing papers with. We got one when I went to Japan. The poster was research that we do together, and we had a paper published together. And my other friends, some of them are in private practice, so they don't do much academic work. Some of them are already consultants, so it's really nice to keep in touch and with your friends, and you can still have some discussion about ortho as well after that. Okay, so that's the end of my lecture. Thank you for listening. And I'm open to any questions if you guys have any questions.
Thank you very much, Dr. Asma, for your enlightenment lectures. That we very, very like, this is the new for us. And to see your life in London and Edinburgh, that we haven't come there yet, it's very bright. Maybe for the next students, perhaps they want to extend their lectures after the specialty. Perhaps maybe you can ask Dr. Asma how to take the philo, yeah, to take the master MOrt, yeah, Dr. Asma.
Yeah, the fellowship, yeah, is actually sometimes there are announcements that we're not aware of. So my consultants or my friends will tell me to apply. So yeah, those are the things that you can watch out for. Especially if you're members of, if you've done the MORTH examination, you become members of the Royal College. So it's only for people who are registered with the Royal College. So you need to be a member in order to apply for these fellowships. Yeah.
Oh, okay. So they have to pass the Edinburgh examination first, yeah, doctor.
Yeah.
Who want to try the Edinburgh examination? Someone? Perhaps later. Okay, thank you, Dr. Asma. We open for the question. Maybe someone who want to ask about something, perhaps about the examination or maybe about the or we open the discussion session.
Good morning. May I ask some questions?
Yes, sure.
Okay.
Have you phrased yet, Claudia?
Yeah. Hello. Good morning, Dr. Rasma. Actually, it's very interesting topics that very uncommon, especially in Indonesia. Yet, I'm quite looking for the explanations for a very long time. I have some questions. First, sorry, I'm still in clinic. I have some questions. First, why you choose membership of orthodontics and Endeavor either than Royal College Surgeon, like I think UK and I don't know one more uh, RCS. The second one, you you said that you have like a consultant for sharing about your case. Is the consultant need to be to have previously registered as MORT also, or it can be your lecturer that have a senior and advanced experience. Thank you.
Thank you for the questions. Good questions. So I think what you meant was, why did I choose Edinburgh instead of London?
Yes.
Yeah. So yeah, I chose Edinburgh because Edinburgh is so the unseen cases are similar, but it's different in terms of that it's a Viva style exam. So they ask you questions, like they give you, like I said, they give you questions on, okay, this is a peak height chart. Explain what you know about that. This is a NITI curve. Explain what you know. Instead of London, it's an OSCE style. So you go to a station, you have to trace a cab. You go to a station, you get an impression, for example, and then you tell us what's wrong with the impression, for example. So it's an OSCE style where you go from one station to another. When I went to the MORTH revision course, we have to do both types of exam, and I did a lot better in the Viva. So I think in the Viva I got like almost full marks, whereas at the OSCE I passed, but I did better in the Viva, and I find Viva was a lot less stressful. But at the moment, I think a lot of orthodontists are a bit angry at Edinburgh because I think in the future, they're allowing general dental practitioners to take the exam, which kind of like, it's supposed to be a specialty exam. So there's some people saying that London is better in terms that it's more exclusive for orthodontists. But at my time, there was no difference. So I mean, I think it's still okay to take the Edinburgh. Um, and the examiners, from what I understand from for many years, they're a lot more friendlier than Emorth London examiners. Emorth London examiners are really, sometimes they say, are really brutal. Like my friends thought they failed the exam after they had the exam, whereas I thought, oh, the exam was so nice because I was so confident that I asked, because my husband was going to get me a bag after that, and I was so confident of the exam, like the results aren't out yet, and I asked my husband, so yeah, when are we going to go get the bag? That was how confident I was. It was so funny. And my husband's like, you haven't got the results yet. So yeah, I find it a very pleasant experience. So that's why I took Edinburgh. I hope that answers your question. So if you're more of an OSCE person, maybe London is better for you if you like going to stations and doing things, I find it very stressful, to be honest. And does that answer your question, the first question?
Yes, really answer. I just thought that they have same I think two examination, but in the same style. But I just know that it has the difference in the
Yeah.
second examination.
Yeah, so if you look at UKM, we used to have a conjoined examination with Edinburgh. So our UKM style for our postgrads, even the final exam is more Viva style. If you look at University of Malaya, when they have conjoined examinations, it's usually with the London, because most of their graduates they did the London exam. So like Prof. Adiba, etc., they do it with the London. And I think UITM as well. So they do OSCE style exams. So it's different in that sense. So for us, we all used to the Edinburgh style, so we do that for our postgrads as well. So yeah. And for your second question about consultants helping with the exam seen cases, right? Your own cases. It doesn't matter, although all the lecturers in UKM, they're all coincidentally, they're all MORTH, they've all done the MORTH examination. But I think it doesn't matter because it's about your consultants helping you to, going through the potential questions and asking them if the cases are suitable for exam or not, if it has a nice finish, if the plan is suitable or not. So I think it's okay for them, to be, as long as they're an orthodontist, I think it's fine for them to help out. Yeah.
Thank you very much, Dr. Asma, for sharing the experience and for all the answer of my questions. Thank you very much. I hope can see you and have more interaction about this membership of orthodontics.
Okay, no worries. Thank you, Euphrasia.
Thank you, Dr. Euphrasia. Maybe you can that you are from UKM, Gajah Mada, or somewhere.
I'm sorry, I haven't introduced myself. I'm a Francia Claudia. Nice to meet Dr. Asma and also the Idcsu department. I'm from Universitas Gajah Mada, Yogyakarta.
Nice to meet you.
And currently still a resident.
Which year? Which year?
I'm sorry?
Which year? Resident?
The third year.
Wow, okay. So it's 4 years, right?
Yes.
We are in Indonesia. It is only 3 years, Dr. Asma.
Oh, it's only 3 years. Okay.
Yes, but sometimes we extend a bit, maybe 1 semester or 2 semesters. Is it Dr. Euphrasia? Semangat. Hopefully you can finish your exam.
Good luck. Yeah, for UK for Malaysia to be qualified as a specialist, the training in Malaysia is compulsory to be 4 years. It's written in the specialty.
Yes.
Yeah. So you guys are lucky you can do it in 3 years. So, but for the UK, if they grad from the UK, they allow us to do in 3 years.
Oh, I see. But I think in UKM, you have to finish about 40 cases, yeah, Dr. Asma.
So we have now I think it's a requirement to debond at least half of the cases. So if you get 100 cases, yeah. So now the MQA, there are new requirements from the MQA. So if there are 100 cases, for example, usually they get 100 at least. They need to debond at least 50.
15 minimum.
50.
Listen, 100 cases, 40 for your own cases, and the 60 from the turunan, yeah, Dr. Asma.
No. So 100 new cases. Yeah. So I think about 100 new cases. Some are transfer cases, but I think 100 new. So the one that they debond, the 50 that they have to debond is the one that they start off with. So it's not the transfer cases or anything.
Oh, I see. Wow. So many patients came there, Dr. Asma. Actually, in Medan, we have to find our own patient because not too many patients want to come to the hospital. Hopefully we have many.
Yeah, I mean, for UKM, we also don't have that many at the moment because they've increased the price. So what we do is we create a QR code and we put it on the university website for patients so they don't need to screen at the main clinic. When they screen, they straight away go into our waiting list. So we'll screen them right after. So we get a lot of patients from there if you want to try, something similar. So we do a QR code and we say, you can have ortho treatment done, at the university with, it has all the details there when they scan and then they put their details in and then it automatically goes into our waiting list. So that's one of our initiatives after COVID, to get more patients.
Or perhaps we can discuss it later, Dr. Asma, directly. Maybe I can WhatsApp you about this. Okay, I think we cannot take a longer time because we have to wait another guest lectures after this. We have from the radiographers, Dr. Novo. He already waiting outside, and we cannot take another question, Dr. Asma. We continue for the. certificate, Dr. Asma. Maybe we cannot give you anything for now, but we give for the appreciation for you only the certificate. Is it okay, Dr. Asma?
Yes, I mean, that's fine. Thank you very much. Thank you very much for the
Thank you
invitation.
very much. Perhaps we will WhatsApp you for you for this certificate directed for you. For the next agenda, maybe we can take the picture together with Dr. Asma, but Dr. Asma is of course in the screen, and we join in the samping Dr. Asma.
Yes, thank you so much again for having me, Dr. Elera, and everyone. And I hope you guys benefited from the talk.
Pasti, Dr. Asma. Very, very much benefit for us. Okay, come forward, everyone, please.
Okay, ready? Terasin ya, Pak. Ini di depan sini nggak apa-apa dong, satu dok di depan TV satu ini nggak apa-apa. Iya. Okay, ready? 1, 2, 3. Again. 1, 2, 3. Ambil. 1, 2, 3. Okay.
Thank you.
Thank you very much, Dr. Asma, for your lectures. Hopefully, we can meet later.
Yes, inshallah. Hopefully to see you again too.
Yes. Okay, we close for the hybrid section for today. Thank you very much for Dr. Asma to give your lectures, and thank you very much from University Gajah Mada to join our lectures. And for other university, I cannot mention one by one, maybe from University Indonesia, but some of them joined to TAAO, Dr. Asma, so cannot join for today's lectures.
That's okay. Thank you so much, everyone.
Thank you very much. We close with Alhamdulillahirabbil alamin. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.